we started inviting some of the OR staff, and we made it an event on a weekend. Some would volunteer. Some even had some support where they could use it as part of their shift. But I would buy pizza. I'd bring them in, take them to the warehouse, and we would count product.
Clock in, scrub up, and join us behind the red line. You're listening to First Case, a perioperative podcast bringing you exciting interviews, engaging discussions, and innovative solutions that are changing the way patients receive surgical care. Each episode, we talk to frontline staff, perioperative leadership, and nursing entrepreneurs from across the country as they share their stories, experience, and expertise on the industry we love. From the back table to the boardroom, from wheels in to wheels out, we tackle the real-life issues affecting the OR. Whether you're tuning in for surgical service education or inspiration, we're glad you're here. And now, it's time to roll back and start the first case.
This week on First Case, we speak with Garry Skinner, president of GSC Consulting Incorporated. Garry is a senior executive, change management expert, and process-driven leader, providing a consistent level of successful transformation. He's a trusted consultant and advisor with 20 years of healthcare experience, including financial analytics, executive-level sales, strategic implementation, sourcing, contracting, supply chain management, vendor strategy, and logistics. His ultimate goal is to improve financial performance while securing a patient-focused mission. And so I know Garry pretty well and invited him to join us on this episode of First Case because I do feel like this conversation, and we recently did an episode with Dan Pfister on the very similar topic of just bringing supply chain and the OR closer together for just a more successful mission to serve the patients in our communities. And I can tell you that Garry's going to go a different direction and really focus on how to foster that relationship. And he's got some vendor experience as well. So I'm sure we'll get into that.
I think having a discussion about the relationship between the OR and OR leadership and materials management is one that we really need to have to see where we can work together and how we can all ensure that we're giving the patient the best experience every time they're here.
All right, we'll be right back after a short break with Garry Skinner.
You're listening to the First Case podcast.
Joining us now is Garry Skinner, president of GSC Consulting Incorporated, and also my co-host for one of our sister podcasts, Power Supply, focusing on materials management, supply chain, and strategic sourcing. And so we're going to be talking about partnering, and hopefully we'll role model a little bit today. Garry, thanks so much for coming on the show.
Thanks, Justin. Looking forward to it.
So why don't you start giving everybody a little bit of your background? Because you've worn a lot of different hats in healthcare.
No, appreciate it, Justin. I kind of wanted to name my company Full Circle, but it was always already taken. So I started on the vendor side. So a little bit of pharma way back in the day and got into some medical device with spinal cord, neural stimulation, and then rolled into spine, medical device and spine for Synthes, and then did some DePuy Synthes trauma and spine as well. And so quite a bit of time in the OR. So from the vendor side, I kind of made that flip and learned everything I ever wanted to know as I was hired on the group purchasing organization side and learned about the contract management side, the sourcing, the supply chain. Really started as a person in the OR, just working on physician preference items, moving it forward, and then worked my way up to the top and managed multiple hospitals and some systems as a GPO, Chief Resource Officer. And then about 3 years ago, kind of went off on my own and started my own business and have been very humbly been successful and enjoying the ride so far. And then met Justin. So here we are. So.
Well, you've got something in common with Melanie when you talk about that trauma and orthopedic background. That's for sure.
Oh, yeah. Ortho spine, do a lot of that. I like doing spine cases. They keep you busy. And we do a lot of work with vendors and a lot of different instrumentation and things that we need during our cases to keep them going.
I wonder if Garry did all of the annoying habits that some of your vendors do today.
Did you hand your implant log to the nurse as the patient rolled out of the room?
No, I did not.
He pleads the fifth.
We're going to back up right now and say there are good vendors, good reps, and there are okay reps, but we definitely had a part to play, and some of them are amazing, I will tell you. And some of them are just, overstep the bounds once in a while, just like in any other kind of a job. Once in a while, you got to push them back, right, Melanie?
Yeah, definitely so.
So, Garry, one of the reasons that we have you on the show, right, is to really talk about the relationship between the OR director and materials management or, other members of the supply chain organization just in general. But we're going to focus on these two to start the conversation today. And if for any other reason, then it always seems to be a source of conflict, or if it's not conflict, it can be a strained relationship sometimes. And so I want to have you talk to us about like the way it can be. Okay. So good and bad, because I'm sure you've seen both scenarios in your career.
I will try not to talk too long on it. Cut me off if I get going into it too much. But I will tell you, number one, I think it's very, very important. The OR director with supply chain / materials management, whatever you want to call it, goes hand in hand. You can start right into price, but I really don't want to talk about price until you really get to talk about mission and patient-centric focus. It's about mission and value. If you don't have quality, mission, and value, you have no fiduciary responsibility, because you have to keep that mission in the back of your mind. It's really a patient you're taking care of. So I think once you get past that, that is a really good lead to work with the Melanies of the world and dive into the surgery directors that are really ultimately, that's their number one goal. Make sure my product's on the shelf, make sure I'm taking care of my patients, making sure it's here on time, and efficient OR management to get them in and out. So I think starting with those two values and moving in that direction is the first start in building a really healthy relationship.
So you kind of said, I think you answered my second question, which is the way it should be, right? Because what you just described is the way that it should be. But what does it look like, when it's not working well? What can it be when it's not good? How would somebody, and I know they already know, but how would somebody like really look at a situation and say, yeah, this just isn't working out? What kinds of things are happening?
Yeah, no, I think the scenarios where it becomes transactional and it's really not everybody in the same room, when you're not taking care of your surgeons, or the ultimate goal is to take care of the patients. When you become that transactional piece of supply chain and you're walking down and you're talking about the price of implants when you don't know really what the implants are being used for and thinking it's all based on price, I think you're really not going in the right direction. The big part, I think, too, is the vendor management. I think it's a really big responsibility, is having the right people in the room, really being effective clinically to help support the case to move it forward. I really believe that a vendor's role is supporting the ultimate outcome, supporting the staff, the circulator, the nurse, the surgeon, and having everything ready in time before they even get there. It's not a time to sell. It's not a time to bring in other products. It's a time to take care of the patient. There are times to have those business negotiations and those contractual obligations that we will always be a part of as we move forward. I guess it comes back to it. It's a collaborative effort with multiple individuals, with the surgery director being the lead of that, and then the supply chain executive, all the way to leadership. C-suite needs to be a part of that too, because it really, really is an end-to-end product. It is the start of the case with the implants to all the way to rev cycle. And I think if you start thinking in that context of that relationship with supply chain and surgery, then I think they have a much clearer picture of where things need to go. So it's not transactional in the least part. It needs to be a very collaborative, proactive response, and it's an ongoing, real-time adventure. So just moving it down.
So, Garry, in my consulting role, I've been to a lot of hospitals, just like you, and it surprises me sometimes, the relationship between materials and the OR director. Sometimes you'll have an OR director who thinks they know more than everybody else, and they don't want to listen to the materials person. They just want the materials person to do what they are asking. And I've also seen it the other way, where materials kind of takes the lead in the role. So how do you work towards developing a collaborative and professional relationship between those two roles in the hospital? It's so important.
Paul, that's a really, really good question. And, as I think about that and I pause about time, it does take time. I think you have a culture that probably has been built over where materials management was receiving, distribution, shipping, handed off to a buyer, look at the contract. But I think that's really, really evolved. And I think it's become more of you talk about non-labor expense. Supply chain is in the middle of all of that. Obviously, we have some OpEx in our own supply chain, but it takes time to build that trust. I think really just being boots on the ground. Don't live in the warehouse. If you're a supply chain director, get out of the warehouse, put a pair of scrubs on, put a bunny suit on, put everybody got to go down in the OR and meet the staff at 6 a.m. to really just be a fly on the wall and understand what they're going through, understand what they're preparing for, really, really understanding the flow of what they're looking at. If they have 7 ORs or 70 ORs, what does that look like? If you're sitting outside of that room and scared to put on the scrubs and your booties and to go in there and take a look at things, I think that's probably the first thing that's going to be amiss. You don't even know what we do here. So I've even seen where we've done some onboarding of supply chain individuals where they actually would be a part of a case. They'd actually shadow and be put in a corner. This is where you're at. This is where you're going to sit. Melanie would say, you're right here. Don't move past me. You're fine. This is your window of where you can preview the hip or the spine case or whatever it would be. And just to really see the room, what happened. So understanding that business, being a true part of it. Don't ever forget about the mission. It's all about the patient. Just takes time to build that trust, Paul.
So why don't you give us some tips too from the other side, right? So the people listening to First Case are, in the OR and they might interact with somebody from materials management. So you were kind of talking about some things there is the best ways to approach the clinician. And I'm glad you started there, but how can clinicians wind up interacting with materials management? What are some best practices for engaging them, and what do they have to gain by having that relationship?
Justin, really good question. It's kind of the vice versa. It's like, what's supply chain doing? What are you involved in the warehouse? Perfect example. We had both periodic and perpetual inventories that we had to manage or semi-annually count. We did our own ABC inventories, on a monthly basis, but we would have these full-blown 16 million, 8 million, and we had to count each product by hand and validate it with accounting. We started inviting some of the OR staff, and we made it an event on a weekend. Some would volunteer. Some even had some support where they could use it as part of their shift. But I would buy pizza. I'd bring them in, take them to the warehouse, and we would count product. And it sounds like the most mundane, boring thing ever to get done. It has to be done. But I tell you what, the amount of information that was learned from the clinical side to the supply chain side and the time you spent counting a warehouse from, 1 o'clock in the afternoon till 8 at night, and you had that fellowship with each other. They understood what you were going through, and they kind of got to see where, hey, if it's coming into the warehouse or if it's coming into the hospital itself, if they have a warehouse on site, hopefully it's on site, just to see that momentum of where it goes and how they keep it and where it should be. And sometimes the clinical staff had some ideas of moving things around too. They had some best practices, like, why is this here? Maybe this should be here. Or they'd see a product and go, this has a min-max of 1, 2. We haven't used this ever. We're done using this. And obviously we had an obsolete inventory. Like, they could see things that from a clinical perspective would ask questions. At the same time, we were doing a full circle approach where we want to be in the OR and they could come see and help us with some inventory. So I think it's one good example that was beneficial, what I'd seen in the past.
Okay, you're talking about inventory, which makes me think about products that we deal with in the OR. Now, obviously, because of the pandemic and then generally just because of supply. Sometimes things get subbed or we get a substitute. Don't always get told about it ahead of time. And if that's the case, you have a doctor, say, whose preference is sterile cotton cast padding, and we've got sterile synthetic cast padding, and he loses his mind because he won't use the synthetic cast padding. But then a substitute because something's back ordered, at least is kind of understandable. But then sometimes the supply chain somewhere up the line decides we're just going to change. We're not going to have Dermabond anymore. We're going to have Secure Seal because of price or whatever. And we don't know about that either. And our surgeons get upset. So what's the best way to deal with products that are maybe back ordered or changed, but communicating that to everyone so that we can all be on the same page?
Oh my gosh, Melanie, I'm feeling your pain. I'm hearing all those conversations. I've been down that road. No one wants to be blindsided, period. And the back orders come. You run out of silvers, you run out, you just run out, and stock happens. PPE happened. The pandemic was an anomaly. That just kind of hit everybody, by surprise. But when I think about product being ready to be subbed out, we always did proactively as best as you can. And I would recommend it. Get it. You may not be able to get it through your clinical value analysis team as quick as possible where they make the recommendation proactively. But if you can get it in the hands of that surgery director or that circulator to put it on the shelf and have a mini trial, use the vendor. Bring the vendor in. Say, we're bringing vendor A in because we're running low and we do have a sub in place. But if we can get a piece of that product for them to see it and get some sort of a clinical approval, especially on like I think about the pandemic, it was so fast and everybody was grabbing whatever they could. And sometimes putting it through the whole clinical value analysis piece, you didn't have time, but you had to get it down to that OR and you got to walk it down there. That's the whole thing. Like, get out of your warehouse, walk it down there. Who's ever in charge of your inventory, whether it's through supply chain or it's a dotted line from the OR to supply chain, they've got to see it, touch it, feel it, sign off on it if they can, and get it in the hands of as many people as they can. So that proactive support, I think, is huge. From a contractual standpoint, I would really, really hope that as these discussions are taking place, you're bringing in the clinical people to have dialogue, and it's not just a sourcing, pricing, contracting discussion. Yeah, set it up, get it moving forward. If it's an RFP, if it's a sole source, or you're moving it to whatever you're trying to do, there is a big time trial in place, and there's got to be in my mind, a clinical value analysis team that has the right players, the right key stakeholders in mind to make sure they have a sign off, because the biggest issue you don't want to run into, you just said it, going to synthetic when surgeons like, no way, I'm not doing it. That's like just changing. You think a safety needle is the safety needle. No, they're not. You got to have a whole training program on that for everybody to feel comfortable. So key stakeholders, proactive communication, samples, sign off when you can, whether it's in the OR or whether it's, up in ICU too, because a lot of those patients travel that way too. So you can't forget the other key stakeholders that may not be down in the OR as well. So, if you change compression sleeves down in the OR at post-op and they're going up to ICU, you better let everybody know. Everybody has got to be a part of that. So I hope that answers your question, Melanie. Hope that kind of gets in the direction we're going.
So, Gary, I've got a question for you. I know during the pandemic, we've had to adjust for the most part and go with the flow at most hospitals to get whatever they can to be able to do their cases. But now as things start to normalize again, many times, especially in orthopedics, you may have two competing groups that one may prefer a particular company over another. So in your efforts to standardize, how do you deal with that situation? Lots of times hospitals will say 80-20, but if you've got two big groups or two big spine groups, orthopedic groups, what have you, that have these high dollar implants, how do you manage that? What are your options? When I worked with Tenet years ago, they came up with a plan to have a standardized price for all companies. They
capitated
pricing based on category of implant, like level 1, level 2, level 3. And That worked for a little while until the companies got around it by, having a specially needed device for a particular case and charging full boat on that, So that was one method of getting around it. But, you've got two groups you want to please. How do you please them both?
Paul, I think whenever you're looking at reducing the number of vendors, whether it's in ortho or spine or trauma, CMF, whatever you're trying to do to reduce the number of vendors, I think there's a couple key things you need to make sure of. One, you've got to be proactive in letting the surgeons know that you're doing this, because the moment you start to reach out to the vendors, there's some really, really strong relationships. If I'm a vendor and I've been a clinician with them for 10 years, they trust me usually in that OR to be a big part of that team. Not only the surgeon, but the surgery director, the circulator, the nurses. They know the ins and outs to make sure that patient is being taken care of, and they're an asset in the OR all the way around. So I think one, if you're looking at trying to reduce the number of vendors, you're looking at another initiative, you first have to be proactive, not only with the C-suite all the way down, but with the surgeons as well. And I think you start looking at the current item master. I think you have to look at what they're currently using. I think you have to say, this are all the products you're using right now that are on our item master that we're billing out, right? We're billing those out. But as part of this initiative, as we move forward as either a cost reduction or a long-term plan or a growth incentive, whatever you're going to have as a part of this, anything that's going to be new has to go through a process. It has to go through whatever means you have set up, whether it's an external vendor or it's an internal committee that evaluates all new product coming in, because premium product a lot of times means premium price. And I think we need to be very aware before a vendor brings it in and shows them a shiny new penny that they understand the process as well, to say, we can't even bill for it. It's not even in our item master. You're trying to bring this in on Friday. We have to go through rev cycle. We got to go through finance. We got to go through our IT to get it on our item master. There are all these bits and pieces and processes that probably are not going to get you paid. Probably not going to get your company paid, and they're not going to get paid their commission. So I think pulling that vendor in to understand that if you have a specialty product, here is a committee that's going to evaluate it. It has to be approved before you bring it in. I always kind of like coining the term, if you don't have an item on contract, you're probably not going to get paid for it. So before we get it approved, don't bring it in. And I think letting the vendors know that. I think between the surgery director and supply chain, a lot of times the vendor will go to either one to try to get that product in. I think pausing a moment to say, we're all on the same page. You need to submit it through a form. You need to submit it through an email, whatever, to get that started so it can go through a committee for approval before they just bring it in. Because the last thing you want, Melanie, and is to bring a new tray in and you have no idea how to use it. I mean, that's a whole nother thing. You got to bring it in. Sterile processing needs to know how to clean it. They got to get it in their inventory. Is it going to be on consignment? There's all these bits and pieces that have to come into play. So developing an internal committee, I think, is really, really important for any of these specialty products, and having the vendors go through a process and a form.
So you were just talking about how to engage surgeons, and I think that's a really important part of this conversation, right? Is not just, communicating to them when you're looking to make a change ahead of time. Like, I get it, being proactive, but in talking about engaging surgeons and establishing those relationships proactively, what are some best practices for that? Like, when do you get them engaged you kind of just said, we're going to look at it. We don't even know if we're going to do anything yet, but we're looking at it. So it seems like pretty early. So, how do you get them involved? How do you get them to care?
Oh man, Justin, I love this question. And, in my previous experience, I actually clawed my way into recruiting. I mean, I found out when new surgeons were coming in, I didn't really need to be part of this, the new psychiatrist coming in, because there wasn't a lot of supply chain. But if we had a new surgeon coming in that was brand new, man, they started pulling me in because it was important to know what they were trained on. Melanie and I were talking about that earlier. If you have someone that's trained on Smith & Nephew scopes and you are completely not even using Smith & Nephew, for an example, it's very difficult to say, we're going to buy you brand new inventory. We're going to start over. We're going to train everybody. But if we can meet with those surgeons when they're looking at coming to that hospital to start their work after their fellowship, what were you trained on? What do you need? Spine. What kind of microscopes do you use? That's a whole nother one. I mean, you know how much a brand new microscope costs? It's a lot of money. So, and you don't really rent those or lease them or consign them. You got to pay for them and they're expensive. So, you never know what's getting promised too. You have to be so sensitive of that. As the recruiting process comes in, it's like, what do you need? Send me your physician preference cards. I need to know everything that you use. So we're ready to onboard you. And that starts right out of the gate. And as soon as the surgery director has them, supply chain needs to have them. We need to know the inventories we have. What's our min maxes? What if our volume's going to double? I mean, that's why if we know ahead of time, right out of the gate, that Dr. Smith was coming in and they were heavy diffuse synthes, we know that we're going to have to double up some more inventory. We know we're going to make sure we got the right things, on the shelf for them to use to make sure ultimately they don't have to worry about it. It's about taking care of the patient. They just need to know they have their stuff there, right?
And Garry, you just said something along the lines of, well, what if our volumes are going to double? Well, they always tell you that the volumes are going to double because that's the expectation, but they don't always double, right? That's
so true. And it takes time to work that up. I mean, you're coming out of fellowship, guy that's been there 10 years, obviously he's going to get things done a lot quicker versus a surgeon that's been there, that's just starting. It's going to just take them time. And, we're going to help them get there. So, Melanie, you were going to say something. I didn't mean to cut you off there.
Oh, no, it's fine. What you were saying about having everybody involved when a new surgeon comes to the facility is crucial. Part of what I do where I work is get our team ready for a new orthopedic surgeon or somebody who may come on board. And the last few meetings we've had sterile supply, we've had materials management, we have the team leader for the service, we have the director, we have the OR manager, we have everybody in there because we all need to know what this doctor needs. And one of us can't do it by ourselves. I mean, we need all of us. And then we're looking at increasing our par levels to make sure we have the right supply. What instruments do we have to order? All of but it is crucial, like you said, to make sure that materials management is in those conversations at the beginning and not just getting an email on the back end that says, oh, by the way, we're going to need X, Y, and Z. Can you order it? Because that doesn't get us what we need at the beginning. I just think it's very crucial.
So true, Melanie. And I think about those meetings, and not just have meetings to have meetings. I'm always like meetings that make sense because I always count the labor hours in the room. It's just weird. Like you got 6 people in the room. They're all directors. You're like, the numbers are just ticking away. It's like OR time. How much anesthesia time do we got going? It's by the minute, and so I'm always evaluating. That's an important meeting that makes sense. And the sooner we can be on board and know about it. And I was right down the hall in a couple different hospitals. I could walk right down to the main recruiter and I could see her board and I knew the titles and I knew what was going on. She's like, come on in anytime, Garry. And if we need to sit down and talk about this, definitely. And I'm going to invite you to the meetings I know you need to be at. So I developed another great relationship with the recruiter. And sometimes that recruiter is not internal. Sometimes it's a total external recruiter that's outsourced. So you almost need to get to know them as well. So they're including you. External recruiters aren't thinking about supply chain. They're just thinking about getting that surgeon on board. So the sooner you can know that these people are coming in, we're all under the same NDA. So just being really, really proactive ahead of that time, because it does take time to get all that set up, especially with the vendors too. If we're going to do consignment, that's another piece that we have to think about when they get on board.
So Garry, frequently in going into hospitals to assess them, we find that their consignment inventories are not really being well managed, and the staff don't know if they purchased the initial inventory or if it was consigned, or is there special pricing for the consigned items. What's best practice in terms of managing consigned inventory in the operating room?
I think that's a very valuable topic to discuss, and I think you got to define what's trunk inventory first and what's consignment. I think some people may think that trunk inventory brought and put in some storage space close to the OR is consignment. It truly isn't. It's really a liability if you're not careful, because if any of that walks out of the institution, I think there's some ramifications that probably fall on both individuals. So I think having a very, very detailed consignment inventory is crucial. And the number one thing first is just to go through it. I remember when I started as a vendor, I didn't have a very good inventory list, and I started with approval from SBD. Imagine this. I asked to unwrap all my sets and take pictures with an iPad back in the day and made sure the inventories were correct. After I knew that, I didn't ask the question, Paul, what's owned? What's consigned? That was a whole nother month and a half to figure it out. So it just took time to really evaluate it. Once I had a very good, clear inventory, it was good. And I managed it all the time. But from a supply chain side, I think as part of the contract, when you go to talking to your vendors, consignment needs to be part of that appendice too. There's got to be some language in that sourcing and that contracting that talks about what consignment looks like. But I've seen some best practices, and for the end users out there, is there's some really, really good vendors out there, and there's some really, really good vendors that care about what they're doing and clinically are very, very good and very good at their sets. They know everything in it, and they manage the inventory. We got to a point on a quarterly inventory where we would sit down with the vendors and validate what was on consignment. It was basically, we had the language already built within the system or the hospital of what consignment was and when it would be counted and who would count it. Supply chain and the vendor would do it together. It was kept on an attachment, just like an appendice, in an Excel document. What's the name of the set? What's the quantity on hand? What's the Lawson number? If we had a Lawson number, we'd even take it to accounting and tie it in there too. But we would count these on a quarterly inventory and go through them. And we would say, this room is not trunk. This room is consignment inventory. No boxes. Boxes are out. These are sets that we know that have a consignment inventory, and you will not go in this room and you will not have approval to use this room unless we get an inventory set up on consignment. Think about that from a vendor perspective. How much easier is it to have it on site at the hospital versus packing it in and out of your trunk or calling it in and having it shipped? Shipping costs, you start thinking of all this cost associated with it. But being able to be on a consignment inventory list that was validated quarterly, that was you're working with your vendors to understand what needs to be there. And then the last piece of that is, you know what? If it's going to be approved for consignment, it's got to be approved by the surgery director. Surgery director's got to make that final call. You know, Dr. Smith says he needs it. Does he really need it there? I think there's some numbers that are about the cost of space in a hospital. There's limited space. We all know that. So the sets that need to be there. Obviously, trauma, big one. There's some spine ones and other pieces, but the surgery director ultimately made the last decision on approval because she knew what needed to be there. And then we would manage the contract, manage the inventory, and make sure it was approved to be there. So we had some really good vendors supporting us there, and was really appreciative to keep things moving forward.
All right, Garry, well, really nice job. And you and I obviously know each other really well since we spend quite a bit of time in the studio together. But is there any kind of final thoughts that you want to add before we wrap the interview?
You know, Justin, the only thing I would say is it keeps evolving. I think you have to build that trust every day, a supply chain to surgery, whether supply chain's managing that inventory, they're managing the core, or whether it's a dotted line to supply chain, it still has to be collaborative. And I just go back to it's patient centric. It's all about mission, quality, and value, and everything else to work out after that. But the collaborative approach, supporting the clinicians that need that support to take care of the patient, that's really what I'm always trying to focus on. And then it seems to fall in line with the fiduciary responsibility down the road.
Yeah, and I loved what you said earlier about trying to find ways to be shoulder to shoulder and to develop that rapport so that the communication is strong, the partnership is strong, and then again, you're doing everything that you can do for the patient by working together. So great job, Garry. Thanks for coming on.
Thanks, Justin. Thanks, Melanie. Thanks, Paul.
That was Garry Skinner, president of GSC Consulting Incorporated, and also my co-host on a sister podcast, Power Supply, focusing on supply chain, logistics, materials management, etc. And it's our second episode in a row, Melanie, where we've had a conversation around really what is a larger initiative, this integrated supply chain where they're, much more involved, much more shoulder to shoulder, strategic. And I can tell you just in the last 20 years, and especially in my involvement in supply chain, definitely the last decade, it's really changing. It's changing in the same way that sterile processing is now becoming much more of a career and everybody's becoming much more aware. We're seeing those two, I'll say, departments in general really on a new trajectory. I think that just their ability and the demands of the job has become much more sophisticated in recent years. And so I think Garry did a really nice job of talking to us about how to get clinicians and those material managers, really working together. And as he said, patient-centered care.
I think that's what's crucial about all of it, Justin, is keeping our focus on our patient. And ultimately, we all have the same goal, is a patient having a safe surgical experience every time they're in our department, in our OR. But his talk about integration and integrating supply chain and materials management with the OR is the way the future should be. It's how we should work together, the way we should be working so that we are...
To make your life easier. I kind of think your day-to-day would go better.
Yes, absolutely.
All right, well, that's going to do it for this week's show. As a reminder, you can help support First Case by subscribing on Apple Podcasts, Stitcher, Google Podcast, Amazon Podcast, Spotify, or your favorite podcast application. We'd certainly appreciate a rating and a review because your feedback is important to the show. And on behalf of Melanie, Paul, and myself, thank you for listening to this episode of First Case.